one of the things, just to give you a little bit of advance notice about the classes that I teach, especially Medicare, is I don't teach anything that I think. I only teach what I know. And so on your slides, you will see, I will let you know the source of where this information is coming from. Because I don't want you leaving today thinking, does she really mean that? I mean, is this really true? Is this really the case? Because that's not going to do anybody any good, especially in the Medicare world where it is so regulated. So what we want to do is we want to kind of take the myth and the mystery out of Medicare today. We're going to be talking about a lot of different topics. So not knowing my crowd, I'm going to start from the very, very beginning, and then we're going to work all the way through to audit. So these are the different topics that we're going to be covering today. We'll have basically an intro to Medicare. We're going to talk a little bit about provider enrollment, par versus non-par versus opting out of Medicare. We're going to talk chiropractic coverage and documentation rules. This is going to be probably the one that the doctors can really sink their teeth into today. Not that if you're a doctor in this class, you'll get a lot out of the rest of it, but that's the one that's really going to, where you'll probably want to lean into the information. Coding and billing, Medicare and the chiropractic profession. We're going to take the myth out of ABNs. We're going to talk about those. We're going to talk quite a bit about Medicare Advantage because there is a huge, huge growth trend in Medicare Advantage patients, and you may be surprised in January with your patients who may have, during this fall's special enrollment period, they may have changed to a Medicare Advantage plan from Medicare Part B. So we're going to talk about that and talk about how you handle that type of a transition. We're going to talk about how to correctly appeal Medicare B and Medicare Advantage claims. And then we'll finish up with a little talk about Medicare audits and how you should respond should you be audited by Medicare. So that's basically what we're going to talk about. I will have break points throughout the day. I do welcome interaction, especially in a 7-hour class. It's like, make me talk for 7 hours. This is just a little bit of a disclaimer. Basically, you're going to see some forms on this presentation that are forms that we have made up for our clients. I am happy to share them with you. Some of the forms are government regulated forms that you'll need to use, like the ABN form, but some of them are basically forms that we have made up that are compliant with the Medicare regulations that I'm going to be talking to you about it. So I just wanted to let you know about that. All right, so let's just go ahead and get started. First of all, how many doctors do we have in the room today? Okay, and then the rest of you are staff, billing staff. Any front desk CAs? Okay, so we've got some front desks, perfect. So this is going to be good for everybody. So we're going to talk, first of all, I want to make sure that you all have a very, very complete and accurate understanding of what Medicare is. So Medicare is health insurance for people who are 65 or older, or people who under 65 that have been approved for Social Security disability, or people who have had end-stage renal disease. Now, the only way you can get Medicare for ESRD is if you are at stage 5 chronic kidney disease, which is basically kidney failure. You have to be on dialysis to get ESRD Medicare, and it's just for that particular diagnosis. So it's very, 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 very targeted. The other population that gets Medicare upon diagnosis are individuals with ALS. So if you're diagnosed with ALS, you immediately become eligible for Medicare. We'll talk about the other eligibility rules for people who have disability here in a future slide. So Medicare is insurance for our elderly population, our disabled population, and special special condition populations like ESRD and ALS. CMS stands for the Center for Medicare and Medicaid Services. CMS provides health coverage to more than 100 million people throughout the Medicare, Medicaid, CHIP, which is the Children's Health Insurance Program, and the health insurance marketplace. So all of your individual marketplace plans are governed by CMS and by CMS rules because those plans are federally funded. So anytime you're working with federally funded plans, you have to make sure you know the rules for billing and for coding and for documentation of those federally funded plans. So I don't know if any of you took my webinar back in February of 2022 was the first time I taught Medicare to the UVCA. I taught it in a webinar form. It was a Saturday, and we had people, all over Virginia, hearing the webinar. But this was a slide from that time. The 2021 edition of Medicare Beneficiaries at a Glance stated, based on the U.S. population of 2020 or 2019 and 2020, 61.5 million people in 2019 were covered by Medicare with 3.8 million new enrollees per year. So this was the 2021 based on the 2019 statistics. So this is the first time that I taught this. Now I want you to remember that number, 61.5 million. Let's fast forward now to 2023. In September 2023, as of actually September 2022, which is a year ago, 65.1 million Medicare enrollees in the US, okay? And of that, 34 million, 35 million are enrolled in what we call original Medicare. We'll talk about the difference between original and Part C, but they were enrolled in original Part B Medicare, and then the others were enrolled in Medicare Advantage or other health plans. And 50 million of the 65 million were also enrolled in Medicare drug. So this is now 2023 based on 2022 statistics. So you can see how rapidly the Medicare population is growing. And why do you think that is? Anybody take a guess? People are living longer. Chiropractic works. People are staying healthy, right? And they're living longer, and your chiropractic population, if you're a chiropractor for any length of time and you're treating your patients and you have great lifetime patients, eventually these patients are going to become Medicare patients. And so, and they're going to be Medicare patients for a much longer time. So 2023, based on 2022 statistics, you see over a 4 million population increase in just 2 years on the Medicare population. The other thing that we notice in this is that the gap between Medicare Part B and Medicare Advantage is closing, as you'll see by this graph. And actually, this graph was from 2016 through 2021. Since then, Medicare Advantage plans nationally have surpassed Medicare Part B. So 51% of the US population now has Medicare Advantage plans versus Medicare Part B. For Virginia, you're behind the curve, and I think that's actually a good thing. I think you're at about 39% of your Virginia population is Medicare Advantage, and then the rest are still Medicare Part B. So it's not catching fire as quickly in our more conservative states, okay? But places like New York, California, and Florida, for example, you're seeing your Medicare Advantage populations in some cases exceeding 75% of the population now have Medicare Advantage versus Medicare Part B. So is it going to be important for us to know how to deal with these Medicare Advantage plans? absolutely, it's going to be vitally important as Medicare Advantage continues to build a stronghold in the Medicare population. And so this was an article that came out in May of this year by Barron's, and basically they analyzed this through the Kaiser Foundation and found that Medicare Advantage now surpasses Medicare. How many Medicare patients are in your state? There is a website through CMS. It's called data.cms.gov, and you can always track this. You can track this every year if you want to. If you're a numbers geek like I am, you know, I love those kind of numbers to see what the trends are. You can actually really drill down. You can drill down into your communities, into your zip codes to see what your Medicare versus Medicare Advantage populations are. So for 2023 in Virginia, 1.6 million Medicare enrollees, 12% of them are under 65. 1/3 of Virginia Medicare beneficiaries are enrolled in Medicare Advantage. And for those of you, you will note that you're finding larger populations of Medicare Advantage patients in the urban areas, okay? The rural areas are still pretty well ingrained into the Medicare, traditional Medicare Part B. But in your urban areas, especially in your lower income areas, you're seeing more of the Medicare Advantage population. Every county in Virginia has Medicare Advantage plans with a ranging availability from 29 plans in Buckingham County to 66 different Medicare Advantage plans in Henrico County. So there are a lot of Medicare Advantage plans out there, and of course we're going to talk about provider enrollment in these Medicare Advantage plans and talk about the pros and cons of even enrolling into Medicare Advantage. In Virginia, there are 42 insurers that offer Medigap plans, and we'll talk about the difference between Medigap, True Secondary, and Medicare Advantage here as we progress on today. As of 2021, Virginia does require Medigap insurers to offer at least one plan to people under 65. So one of the things that you'll learn, and I'll be teaching you about Medigap plans, is that Medigap does not have to insure you. So if you are a special needs population, if you have chronic illnesses, if you have a lot of health problems, and you try to apply for Medigap plans, some plans won't even insure you. They have the right to refuse insurance. But in Virginia, the government intervened and said, if you're going to have patients on Medicare Part B, we have to have at least one Medigap plan that you can offer these populations, and you cannot refuse coverage to them. So that's actually a really good thing. There are some states that don't have that requirement. It's crazy, you know, people, and what it does is it forces people to go into the Medicare Advantage world. There are 24 standalone Part D prescription drug plans as well, and this is 2023 statistics, okay? So let's talk about the different parts of Medicare. I call this the ABCDs to be funny, but because that's what Medicare has, calls their different plans, Medicare A, B, C, and D. So one of the things that I encourage all of my providers' offices to do, you know, like I say, we have about 120 billing clients, and so what we do is, as a courtesy to all of our clients, every year we email them the PDF version of this booklet. It's called Medicare and You. And this is actually the booklet that is given to Medicare beneficiaries. This is not a provider-based booklet. But I'm telling you, if you want to understand Medicare, you get that book, okay? Not the provider booklets that, and the provider regulations, because that's written in governmentese. This is written in lay terms with somebody who has basically a seventh grade education is what the mandate is, that this booklet be written in a manner that somebody with a seventh grade education or better can understand it, right? It's fabulous because it really helps you. It's a great training tool for your staff. It's a great training tool for your providers. Now, it doesn't address like documentation compliance and things like that, but as far as what the benefits are, what the differences are between Medicare Part A, Part B, and the Medicare Advantage plans and the drug plans, this is a wonderful, wonderful resource. It's called Medicare and You. It comes out every year in December. It's online right now. If you go to the Medicare.gov website, there is a link for the 2024 Medicare and You document. I can send it to you as well, and you'll have my contact information. I also have business cards in the back with my email, so if you ever have any questions or you want any of the forms that we're going to be talking about, please feel free to grab one of my cards, email me, and I'm happy to send them to you. So the first part of Medicare is Part A. This is the hospital insurance. So when you work for somebody as a W-2 employee, one of the things that happens is every week or 2 weeks or however often you get paid, out of your paycheck, a deduction is taken for Medicare, okay? And if you've ever wondered what that is, what is that deduction? That is a deduction that goes towards Medicare Part A when you retire. So what happens is when you retire and you become 65, you automatically become eligible for Medicare Part A without having to pay any premiums, okay? There are some rules. We'll talk about that here in just a minute. But Part A is the part of Medicare that covers your inpatient hospital stays, skilled nursing facility care, hospice, and some home health, okay? There is some home health that is covered by Part B, but most of home health is covered by Medicare Part A. So when you retire, you don't have to pay a premium for Medicare hospital insurance. And it was designed to be that way, a catastrophic plan. Then you have Medicare Part B, which is the medical insurance side of Medicare. And this helps cover, and by the way, these pictures are snapshots from that Medicare and You booklet, okay? So basically, I just took a snapshot of that PDF. So everything that you see here that looks really nice, because I'm not very artistic, is cut and pasted exactly from that Medicare and You booklet, okay? So this is what our Medicare patients are learning about Medicare, it's important that you know what they know, right? I mean, this is what Medicare is telling them, so it's important that you understand what Medicare is teaching your Medicare beneficiaries. Medicare Part B is medical insurance that helps cover services from doctors and other healthcare providers. That's where we all come in, okay? So we fall under Medicare Part B, not Medicare Part A. Outpatient care, outpatient surgical procedures, home health, durable medical equipment, and other preventative services are covered under Medicare Part B. Now, both Medicare A and Medicare B are automatic upon reaching eligibility for Medicare. So how many of you have had to have the Medicare talk with your parents, your elderly parents? I have. And so, my elderly parents, when they first became 65, fortunately, Medicare Advantage wasn't really a big thing then, but it started to be. And later on down the road, when they were in their late 70s, they started talking to me about switching to Medicare Advantage. And so I had to give them the pros and cons. Now for antitrust rules, I cannot tell you guys whether to enroll in Medicare Advantage or not. You cannot tell your patients whether or not to enroll in Medicare Advantage. You can't do that. You're not allowed to do that. So if a Medicare patient comes to you and says, should I enroll in a Medicare Advantage plan? Don't be saying, oh, no, it's awful, it's horrible. What you do say is, let me tell you what the difference is. And then you make and if they ask for your opinion, then what you can say all right, is, well, I wouldn't choose it for myself. Okay, you're allowed to say that. You're allowed to say, well, for me, I wouldn't choose it for myself, and I probably wouldn't choose it for my parents. So you can do that, but don't ever, ever be telling Medicare patients not to enroll in Medicare Advantage plans. Because if word gets out, if a Medicare patient calls Medicare, for example, and says, I'm really confused as to what to do, and they talk to a Medicare representative, and that Medicare representative hears that one of their doctors told them not to enroll, they're going to take the name. They're going to say, who told you that? They take antitrust violations very, very seriously. So I'm going to try to be very, very politically correct about Medicare versus Medicare Advantage, and basically give you the same comparisons that you would want to give your patients when they are trying to decide whether to enroll in a Medicare Advantage plan or not, okay? And if you haven't had that conversation with your parents, you probably will at some point be having this conversation, and with yourselves for that matter. You may be having a decision point as to whether you should enroll in Medicare B or Medicare Advantage. But both A and B are automatic. So what happens is if you turn 65 and you have not made an election to go to a Medicare Advantage plan, you'll automatically start having a deduction made on your Social Security check for Part B benefits, okay? That happens automatically. You literally, the patient has to decline coverage in order not to get Medicare Part B. And there may be some instances where patients can and should decline Medicare Part B coverage, and we'll talk about that here in just a minute. Then we have the C of Medicare, which is Medicare Part C, also known as Medicare Advantage. Now, Medicare Advantage is private insurance that is contracted by Medicare, by CMS, to offer health insurance to patients. And this is something that I can tell you, and one of the reasons why we see so many commercials now for Medicare Advantage plans, and where, you know, if you watch TV and you don't have a DVR where you can fast forward through the commercials, you're going to see like almost every other commercial right now is for Medicare Advantage to get people to enroll, and they have all these celebrity endorsements for the Medicare Advantage plans. And what happens is brokers who sell Medicare Advantage plans get paid 10 times more in commission to sell a Medicare Advantage plan versus Medicare Part B and Medicare, or a Medigap plan, a Medicare supplement plan, 10 times a higher commission, and they get it up front as soon as the person signs up with Medicare Advantage. So brokers are pushing it very, very heavily because they make a lot of money on Medicare Advantage sales. And then, of course, the celebrity endorsements, they get paid, the celebrities get paid a lot of money to endorse these Medicare Advantage plans as well. This is private health insurance, so it acts very similarly to the commercial insurance plans we work with. There may be co-pays, co-insurance amounts, different deductible amounts, but we will talk about what the similarities are as well, and what rules the Medicare Advantage plans have to follow in order to maintain their Medicare Advantage contracts. One of the things that you'll see and as you see it trending through the years, you'll see that your Medicare Advantage patients may have to switch Medicare Advantage plans every year or every few years because the Medicare Advantage companies lose their contracts for non-compliance, so then another contract is offered and they have to switch plans because their original plan is no longer even available in their community. And I'm seeing nodding heads because we see this all the time. Come January, you're going to have to be very, very diligent about finding out from your patients. And you can actually start doing this next week after December 7th, because that's the end of the enrollment period for Medicare Advantage. So after December 7th, your patients will know what insurance they have in January. So you can start querying them now, starting next week, and say, hey, did you switch from Medicare Part B to a Medicare Advantage plan? Did you switch from this Medicare Advantage plan to a different one? So you can start gathering up that information before the onslaught in January, okay? So that is one thing that you can be aware of. But that's Medicare Part C, which is private, what they call a Medicare health plan. And then you have Part D, which is the Medicare drug coverage. So this is, original Medicare, which is Part B, did not include drug coverage. So patients who had Medicare had to pay, up until, I believe it was 2000, they had to pay 100% for all of their drugs. And so Medicare gave a supplemental drug coverage. Now, and so if you have Medicare Part B, then you have to have that you have to add that drug coverage to your plan if you want coverage for RX. So for 2023, because we're talking about it, the cost, if the individual does not qualify for Medicare Part A, remember how I said when you take money out of your employment, your paycheck, it goes towards Medicare. In order to become eligible for Medicare Part A, you as the individual, or your Medicare patient as the individual, must have contributed at least 40 quarters or 10 years into the Medicare program, with the exception of SSI disability. So if you're a young person and you go on SSI disability, you don't have that requirement. But if you didn't, and one very, very specific population that usually does not contribute into Medicare Part A are school teachers. Public school teachers in many states do not have contribution to Medicare Part A. So when they retire, they get a teacher's retirement plan that covers Medicare Part A. If you were self-employed and you never contributed to Medicare through your self-employment payments, and you decided not to do that because it is optional, and you didn't ever contribute 10 years or 40 quarters, then you would actually have to pay a premium. It's either $278 a month or $506 a month, depending on your income, to get Medicare Part A. Most of, the vast majority of your patients are going to have Medicare Part A, but it is important to note that there are populations that may not qualify for Medicare Part A, and the Part A deductible in 2023 was $1,600. In 2024, the deductible for Part A is $1,632. Okay, now that's not the deductible that we will be worried about, because we're not hospital. We don't bill Part A, we bill Part B. So the costs for Part B, the premium in 2023 was $164.90, and then the deductible was $226. So the let's see. For 2024, these are the new costs. So the Medicare Part B deductible for 2024 is $240. Yes, you had a question?
Yeah, it said for the Part A that the premium differs depending on how much you and your spouse contributed. Mm-hmm. Does that mean that what you contributed together, or does that mean individually?
Together if you're joint. No, individually, but then they combine it. You see what I mean?
So if your spouse doesn't work at all and you contribute for quarters, it still doesn't count?
It depends. It depends. It could. Yeah. It could be that because in not as much anymore, but it used to be that you had one breadwinner, right? So what would happen is, as long as they contributed a minimum amount, then everybody in that household would become eligible for A, because somebody was home as a housewife or a house husband or whatever. So yeah, so that's a good question. So here are your costs for 2024. Your patients are going to have a $240 deductible. The Part A deductible's gone up to $1,632. Then if they choose Part B, the premium has gone up, I think, $14 to $174.70, or maybe about $11. I think it was $163. Medigap insurance can cost anywhere from $50 to $300 a month, okay? And so these are the costs, and then of course you have your drug plans that also, if you get Part B, and you pay that, $174.70, if you want full coverage, meaning you'd need Part B, a Medigap plan, and a drug plan, you'd probably be paying somewhere around between $300 and $450 a month for Medicare, full coverage Medicare insurance under Original Medicare. So the average cost of Medigap insurance is anywhere from $50 to $300. And again, these premiums are based on health status. That's why premiums can be so much higher for certain patients than others. So if you're a smoker, if you have chronic health problems, your premiums for the Medigap are going to be much, much higher. And the reason for that is because Medicare Part B has zero out-of-pocket expense provision. So how many of you know what out-of-pocket maximums are? Okay, what's an out-of-pocket maximum?
The amount that the beneficiary has to pay in total for the plan.
For the year?
For the year before insurance will cover it 100%.
Right. Medicare Part B has no out-of-pocket maximum assigned to it. So that means it's an 80-20 plan forever, all right? So there's not a point at which when the Medicare patient pays so much into it that Medicare B starts to cover it 100%. So think about that. If you're a Medicare B patient, you have very, very poor health, you see a lot of doctors, maybe you need a lot of surgeries, maybe you have a lot of chronic problems, right? That Medigap plan is going to be covering that 20% forever, okay, on all of the medical services, not until the out-of-pocket is met, but forever. So they're responsible for 20%, which is why these premiums are so much higher, okay? So let's take a look at a comparison between Medicare Part B and Original Medicare and Medicare Advantage. So Original Medicare is automatic. You automatically, when you turn 65 or when you're approved for a Social Security disability, you're automatically eligible, and again, you're automatically eligible for Part A and B. You may have to pay a premium for Part A, depending on whether you made your contributions, your 40 quarters of contributions. So you become automatically eligible. Medicare Advantage patients also become automatically eligible to enroll in a Medicare Advantage plan if they so choose. Now, Part D and the supplemental coverage are optional. They don't have to get Medigap insurance. They don't have to get drug insurance. But if they do, there are going to be extra premium costs on top of the Medicare Part A and Medicare Part B premiums. So if there is a Medicare A premium, but for sure the Medicare Part B premium. So then you have the Medicare Advantage side, which kind of wraps everything up into one nice neat bow, which is your Medicare Advantage plans. Usually the better plans cover A, B, D, and some extra benefits such as health and wellness checks. Some of these Medicare Advantage plans offer gym memberships to their beneficiaries. They really kind of perk it up to give the beneficiaries extra and added benefits. And one of the things that you're going to see more and more of is your Medicare Advantage patients, once they realize if they have like a very, very basic Advantage plan that doesn't give them what they need, they may purchase an expanded plan. And those expanded plans actually for you in chiropractic cover things like exams, x-rays, physical therapy. So there is extra coverage available on about 20% of the Medicare Advantage plans that are out there. So one of the things that it's important for you guys to do is to verify coverage on the Advantage plans that your patient may have and ask if there is expanded coverage or if they simply follow the basic Medicare billing rules and guidelines. Because if they say we follow Medicare guidelines without expanded coverage, then the only thing that's covered is what? Spinal manipulation to correct a subluxation. It doesn't change. The only thing that changes is what is the copay, is there pre-auth required, and things like that. So Medicare Advantage bundles all of these and all of these extra costs into one plan. So, it's very interesting on the, on the A, B, and Medicare Advantage, and this is what, Medicare and You is telling the beneficiaries. So they are telling the beneficiaries that it's likely that if they choose a Medicare Part C plan, that they are going to be limited in their choice of providers. Okay, many of the Medicare Part C plans are local plans, meaning they're only good within the service area of that plan. So if the Medicare patient goes outside the service area, right, and they have Medicare Advantage, let's say they have their permanent residence in Virginia, but they snowbird down in Florida and they have a Medicare Advantage plan, they can't use it in Florida. They have to come back to Virginia to get their medical services, with the exception of emergency services. They can go to the ER, but for anything else, they have to use the doctor that's within their service area. And so this is one of the big things that these brokers don't do a really good job of. They talk to the Medicare Advantage patients about, how much less it costs, because essentially what most of these Medicare Advantage plans do is they offer the Medicare Part B premium for everything. They say you pay that Medicare Part B premium and you'll also get Medicare A, you'll also get the drug plan, you'll also, you'll get all of these additional perks, plus we'll give you a gym membership, right? And so, and a personal trainer, and a latte. They are promising the world to these Medicare Advantage patients, right? But this is the big one right here that is very, very overlooked when beneficiaries are looking to switch from original Medicare to Medicare Advantage. So that's a question that if your patient says, should I switch, from Medicare Part B to Medicare Advantage, ask them, how much do you travel, right? Do you like to travel? Do you have a second home somewhere else? If you do, please understand that if you choose a Medicare Advantage plan that is not, now there are Medicare Advantage plans that are called private fee-for-service plans, PFFS plans. They're pretty expensive, right? Probably as expensive as just staying with original Medicare, but you could use any doctor anywhere in the United States that takes Medicare, okay? But those aren't your $174 a month plans, right? Those are going to be $500, $600 a month plans that give you that expanded coverage to basically see, the service area coverage. So that's a big one. The other is the money, and this is what, when it all boils down to brass tacks, folks, this is what it boils down to for the Medicare beneficiary. You have a Medicare patient who's on a fixed income, they're retired, maybe they're living on a small pension and their Medicare checks, and they're looking at every single dollar that they need to. And so sometimes it's not even a choice for them, it's a necessity, because if they want to get original Medicare, their premiums for all the different products, and they want to be fully covered, the premiums for all the different products are going to probably be twice as much as if they choose a basic Medicare Advantage plan that gives them, local catastrophic coverage. So basically what happens is the difference here is that for Part B covered services, the patient has a 20% coinsurance. Medicare Part C, it says out-of-pocket costs vary, all right? Which means it's very similar to commercial insurance. There may be a specialty copay, there may be a primary care copay, there may be a deductible, and a coinsurance, usually there are out-of-pocket maximums. So once they've paid in a certain amount into their benefits and they reach a certain threshold, then that Medicare Advantage plan should cover it 100%. But essentially, this is what the Medicare Advantage says. You pay the monthly Part B premium and may also have to pay the plan's premium, but these basic HMO plans do not make them do that. They pay the Part B premium, and now they've got an all-in-one HMO plan that they can, where they have the drug coverage and so on and so forth. The other thing is that with Medicare Part B, you cannot buy Medigap insurance. So when we talk coordination of benefits here in a little while, that's one of the big mistakes that I'm seeing when staff members are profiling Medicare patients. So what these Medicare patients are doing is they're bringing you a red, white, and blue card, they're bringing you a Medicare Advantage card, and then they're bringing you an old Medicare supplement card, and you're trying to figure out what's primary, what's secondary. With Medicare Advantage, there is no secondary unless you're a Medicaid patient, dual eligible, and we'll talk about that as we move through the conference today. But Medicare Advantage plans are all in one. There is no secondary plan, there's no secondary billing, again, unless you're a dual eligible Medicare, Medicaid patient. So they don't have to have all of these different insurance plans that they have to keep up with. Now, yes?
I'm so sorry. One of the things that we've seen, or as of last year, that we saw a lot of is patients coming in with their Medicare Advantage card, thinking it was like a Humana, they thought it was a supplement to their Medicare.
Yeah.
So they come in and it absolutely says right on the card, they just don't realize
Uh-huh.
that it is an Advantage plan.
Yes.
Is there any reason that we should not tell them that they need to talk to someone, because if they thought they were getting a secondary, this Medicare Advantage is replacing Medicare, can we do that, or is that a?
No, you can do that. I mean, if they say, oh, I didn't realize that I bought a Medicare Advantage plan, my broker wasn't clear about that, I just thought I was buying a supplemental plan for no extra premium, right? They're thinking it's a supplement to their Medicare Part B, and this is a very common problem, right? The brokers aren't explaining it, or if they are, they're not giving the full disclosure. They're saying, here's the booklet, go ahead and you can see the comparisons, but unless you hear it, sometimes if you see it on paper, it still doesn't mean anything, right? And so we're going to talk about this in just a few minutes, is the different enrollment periods in which you can switch. So if you have patients in January who have switched this year to a Medicare Advantage plan, and they come in and they don't realize that they did it and they didn't really want to do it, you can tell them that there's a special enrollment period, and I have the exact dates on a slide here. I think it's from January to either the end of February or March, where they can switch back with no penalty, okay? So if they want to do that, they can certainly do that, but it is a very small enrollment window. Now, Medicare Part B premiums, we mentioned that it was about $174 a month. For some income populations, the Medicare Part B premium could be higher, all right? My husband actually, he just became eligible for Medicare 2 years ago, so this year, he said, my Medicare premiums just because I told him, I said, you're not going on a Medicare Advantage plan, because he's had triple bypass, so he has, and he has some genetic issues with heart conditions and things like that. I was like, no, we're going to stay with, we'll pay the extra money. He said, my Medicare premiums have gone up. Well, that's because our IRS tax return from 2 years ago was applied, and so his Medicare Part B premium was quite a bit higher than the what he expected at the $174. So these are the income thresholds. If you file an individual tax return, it's $97,000 in 2023, $103,000 in 2024, and $194,000 and $206,000 if you're filing jointly. So if your joint return, shows this as your income, then you're going to have a higher premium. Some of the hidden costs of Medicare Advantage plans, and again, this is something that if you want to show a Medicare Advantage patient, you'll have the handouts, or I can send you a separate slide for this. Most of the low budget, which are the zero monthly Medicare Advantage plans, still require the patient to pay the Part B premium. They don't realize that they're still paying that $174 a month. So it's not like they're not paying anything for it. They still are paying a premium. Most of the budget Medicare Advantage plans are local. We talked about that. If they travel, they can't use it except for emergencies. HMO plans require patient to see a PAR provider. So it's like an HMO. It's all or nothing. If you don't see a provider in your HMO, then you cannot get benefits. And there is an exception for HMO POS plans, but again, those are more expensive, the HMO POS plans. Many of the Medicare Advantage plans are now requiring prior auth for services. And this is something that folks, you'll be very excited if you stick with me until the end of the day. I will talk to you about how you can fight prior auth for chiropractic services on the Medicare Advantage plans. Medicare Advantage plans cannot impose prior auth on us because Medicare Part B does not. All right? So if they're trying, there are appeal rights for that. So if you get denied on a Medicare Advantage plan for a prior auth, that can be appealed all day long and you'll win it every single time. Okay? Yes?
Does that matter if you're participating or not participating on the prior auth?
It does matter.
Yeah.
Yes, it does matter. Mm-hmm. So we'll talk about that. Co-pays can add up if the patient sees their provider frequently. And there are penalties to switch back, which are lifetime penalties. So if a patient has Medicare Advantage, let's say for 5 years, okay, and they decide, I want to switch back, right, to Medicare Part B, Medicare B basically takes the differential in the premiums as if they had full coverage, which is B, D, and the drug, Part B, the drug plan, Part A, if they have any premiums. They take that differential of that past 5 years and they tack it on as a premium penalty for the rest of the patient's lifetime. No, any period of time. It can be 1 year, it can be 2 years, it can be 5 years. But they take that as a differential, they take a percentage of that, and then that percentage becomes an added premium. It's really, really significant. Yes?
Does it work the opposite way? If you want to switch back to Medicare Advantage?
No.
So you're going to answer the question, right? Like, what's the agenda here?
Uh-huh. Yes.
Okay.
Yeah.
Okay. Great.
Yeah. Okay. So, lifetime penalty to add back a Medigap plan, lifetime penalty for late enrollment in Part D. So there's all of these penalties if the patient initially, or they either initially buy Medicare Advantage and then they don't switch within that special enrollment period, there are going to be penalties assessed to their premiums for as long as they have it. And they can get pretty significant the longer the patient has been on a Medicare Advantage plan and then wants to move back into Medicare Part B. And again, the Medicare Part B is doing this, they do it to prevent patients from making that choice, because ultimately the government would love nothing more than to see all of Medicare in the Medicare Advantage world. There's all kinds of speculation that eventually original Medicare is going to go away. I don't know. I don't know if that's going to happen in my lifetime, but that's where the push is. The push is to get rid of that. Yes.
Right now, military retired cannot switch to Medicare Advantage. Is there a plan to change that?
I don't know. Yeah. I would imagine that if Medicare moves towards all Medicare Advantage and they discontinue Part B at some point, they'll have to. They'll have to give them a Medicare Advantage. But the reason why is because Medicare retirees have CHAMP insurance, and so Medicare Advantage does not have secondary. So they can't have CHAMP and Medicare Advantage. They can only have one or the other. So, yeah. Let's talk a little bit about dual eligibles because, some of us, even though we may not take Medicaid, we have to know how to handle the dual eligible patients that come into our offices. So a dual eligible patient refers to anyone that is eligible for both Medicare and Medicaid. And Medicare is always, if you have a dual eligible patient, Medicare is always primary, Medicaid is always secondary, okay? And then under Virginia Medicaid, there are basically six Medicaid MCOs, managed care organizations. So Medicaid is almost all the states in the US have gone to the Medicare Advantage model, where it's not the state Medicaid fund, but it's different Medicaid managed care organizations that a patient can choose to participate with. So very similar, they enroll in the different Medicaid plans. Most Medicaid enrollees have no copay. Enrollees would need to use doctors who are in the plan. And some of the Virginia Medicaid plans will offer extra benefits that traditional Medicaid does not offer. Some of the managed care plans called the Medicare fee-for-service, like vision, hearing, and other benefits. So if you have any questions about the Virginia Medicaid plans, you can, but here's the thing, chiropractic isn't covered in Virginia under Medicaid, but because it's, yes, go ahead.
We have many disabled patients who are being forced to switch from regular Medicare to Medicaid, and they lose their chiropractic benefits. One of our patients, who is a very strong advocate, she has gotten them to switch back hers, back to Medicare. Is there a way we can tell our other patients how to do that?
I can look into it. I can definitely, if you want to send me an email with that question, let me research that for you. Typically we don't deal on the patient side of things, but I'm sure we could find out for you.
I figure if there's one lady who's able to do it, others should.
Yeah, and I don't think you can force anyone really to stop using your Medicare. If you're Medicare eligible, you're Medicare eligible, so. So, under the balance billing rules for dual eligibles, okay, you may not balance bill a dual eligible patient for services that Medicare covers. Remember that, services that Medicare covers. So what does Medicare cover? Spinal manipulation to correct a subluxation, right? AT modifier, spinal manipulation codes, all right? Those are the only ones that are covered. So if you have a dual eligible patient and their supplement is the Medicaid plan, that would normally cover that 20% because it's a non-covered service on Medicaid, but it is a covered service on Medicare, you may not balance bill them. Now, and this comes directly, this is basically copied and pasted from the Virginia Medicaid website. Now, the dual eligible patients on non-covered services, which is what? Everything else, including your maintenance patients, your Medicare maintenance patients, therapies, exams, x-rays, everything else, as long as you have notified them prior to the provision of service that this is not covered and they would have to pay out of pocket, you can balance bill the Medicaid patient for those services, okay? So, don't let a Medicaid patient tell you, well, I don't have any out-of-pocket expense. The answer is that yes, for services that Medicare would cover, but because Medicare does not cover exams, therapies, x-rays, and all of these other services, your Medicaid plan would not even consider it, so it's going to be cash and carry. So then you offer them a cash fee. Yes? You can bill them the full amount. Yes, absolutely. But prior to the provision of service, so what does that mean? You need to have something in writing, right? That where the patient, you can verify that the patient was notified, have them sign a document that states these are services that Medicare and your Medicaid plan do not cover. It. Very simple language on your letterhead, right? List the services you might provide and the costs, like a menu, and say, because your Medicare and Medicaid plan do not cover it, we are notifying you in advance that you will have to pay out of pocket for these services, should you choose to use them, okay? Make sure you understand the difference of what you may and may not balance bill your Medicaid patients on. Okay, let's talk really quickly about the enrollment periods. Generally, you're first eligible to sign up for Part A and B starting 3 months before they turn 65, 3 months after they turn 65. That's a standard enrollment period for any newly eligible Medicare patients. Social Security disability enrollees have to wait 5 months to start receiving Social Security benefits from the date they become qualified, okay, for Social Security, and additionally 24 months before they're eligible for Medicare, okay? So just because they have Social Security disability does not necessarily mean they're Medicare eligible. They have a 2-year waiting period with the exception of ALS and end-stage renal disease. In that case, they're automatically eligible as soon as they are diagnosed with that, okay? And they can apply for that special program. The enrollment periods, October 15th to December 7th, that's why we're seeing so many ads. So December 7th is this enrollment period for our Medicare patients to switch from Medicare over to Medicare Advantage plans is coming up, is almost done. January 1 is when the new coverage starts. And then January 1 to March 31, Suzette, is when they can switch back. So they can try it out for a few months, and if they don't like it, they can switch back. So make sure you let your Medicare patients who may not realize what they bought into, let them know that they do have the ability to switch back during that special enrollment period, okay? There are other special enrollment periods, such as if the patient has a Medicare Advantage plan and they move. Let's say they do move from Virginia to Florida. They're not going to, Medicare says, we're not going to make you wait until the next enrollment period to switch. You can switch right away if you show proof that you've moved, you have a new address, driver's license, right? And they can enroll anytime between the month before the move and for up to 2 months after they move is when they can switch Medicare plans if they move. If they move from an institution and move back home, for example, or they move between institutions, like they go from a skilled nursing facility to a long-term care facility, they can also switch plans if that long-term care facility is not in their service area, okay? So these are just some special enrollment periods that, you would want to pay attention to. All right, do we have any questions about all of this? Yes, no? Yeah.
One, and if you're about to cover it, just let me know. But going back to like the dual plans, I'm starting to see those pop up a lot more as well. And so sometimes is it common to have a provider who participates with Medicare and not Medicaid? And so then if that's the case, would the Medicaid side not even cover what would typically be covered by Medicare? Like say the co-insurance or
They're not, if you're not a Medicaid provider, they're not going to cover it, but you still can't balance bill the patient.
Right.
Yeah,
Okay.
yeah.
Unless they know in advance.
No, you cannot balance bill the patient, period, for spinal manipulation for active treatment. If they're dual eligible, no balance billing for the 3 codes if the patient is on active care. If they're maintenance, if they've signed, and we'll later after lunch, after we're out of our food comas, we'll talk about ABNs. But if they've signed that ABN, that they realize they're on maintenance now, then that's different. Then at that point, you can balance bill them for the, right, because it's a non-covered service. Absolutely. All right. Any other questions? Okay. Let's see how we're doing on time. Good. 10:16. Okay.
I have a question.
Yes.
The 3 codes
Yes.
would be like 89840, 89841.
98940, 41, and 42. Those 3 codes. Yes. Okay. Let's talk a little bit about provider enrollment. So Part B providers are actually, by Medicare standards, are called suppliers of Part B services. So when you see these slides, don't get confused by supplier. Supplier and provider are synonymous in the Medicare world. So these are your suppliers. There are different enrollment forms. We're not going to get into all that. This is not a credentialing class. I can teach one if you ever want me to, but this is not a credentialing class. But your physician, your doctor of chiropractic, or you as a doctor of chiropractic are considered a Part B supplier. There are 2 types of suppliers, group and individual. And so your individual providers are your chiropractors, your groups are your group practices. So if you bill as a group with multiple providers under you, then you will have to enroll your group as well as your individual. I have heard many times over the years chiropractors tell me I don't take Medicare. And so first of all, I ask them, well, what does that mean? I don't take Medicare. And what I hear a lot is, well, I just make the patients sign option 2 on the ABN and we just do it as cash. I said, but do you have a Medicare number? No, I don't. So when the correct answer for a doctor of chiropractic that says, I don't take Medicare, is no, I don't take a Medicare patient, period. I refer them to a Medicare provider, and if any of my patients age into Medicare, I refer them out of the practice. That's the correct answer when you say, I don't take Medicare, if you're a chiropractor. Okay? Any other answer other than that is wrong. And we'll talk about that, and I have some slides that show that. So chiropractors do not have the option to opt out of Medicare the way medical providers do. And the reason for that is because nobody can do what you do, right? A medical doctor can't adjust a subluxation. A chiropractor can. So chiropractors, physical therapists, occupational speech therapists, and I believe there's 1 or 2 others. Anesthetists, anesthesiologists cannot opt out of Medicare, all right? So if you say, I don't take Medicare, I'm going to kind of cover my ears because if you say, I don't take Medicare because I see all of my Medicare patients as cash, that is basically opting out without an opt-out, which you can't do. Yes?
We have a patient who has a railroad Medicare,
Mm-hmm.
but we are participating with the regular Medicare.
Mm-hmm.
Can we offer them cash price? Or
No.
We cannot.
No, Railroad Medicare is Medicare Part B for railroad beneficiaries, railroad retirees, and Federal Department of Transportation retirees. It is a segment of Part B. So, and you don't have to enroll in Railroad Medicare. All you have to do is go to the Railroad Medicare website, apply for an RR Medicare PTAN number so you can file the claims, and you just give them your Medicare PTAN number and your clinic information. It's just an online form, submit it, and you'll get a PTAN, and then you can file Railroad Medicare.
I mean, we used to be participating
You are. I mean, if you're a Part B, if you are a par, if you're par with Medicare Part B, you are par with Railroad as well. You may have an inactive PTAN because maybe you didn't bill it for a long time, but you are par and you are required as such, as a par provider, to bill Railroad Medicare for those Railroad Medicare patients. You can't opt out of Railroad Medicare, okay? Because Railroad Medicare is just an arm of Original Medicare. It's just a different payer, basically, okay? So chiropractors can't opt out of Medicare. They can choose to be out of network with Medicare, or not, what we call non-par, and we're going to talk about the difference in if that's something that chiropractor wants to consider. Chiropractors who are not enrolled in Medicare may not accept Medicare patients, and chiropractors who are not enrolled in Medicare must also refer their patients out who end up aging into Medicare. Okay, so what did we see? We saw that about 22% in some earlier slides of the population in Virginia are Medicare eligible. So my question to you is, do you want to eliminate 22% of the population from your practice? To me, when I hear providers say, I don't take Medicare, I personally get a little sad about that, because who needs us the most, right? These Medicare patients, first of all, in my experience over the years working in chiropractic offices, is that they're among the most compliant of your patients. They pay their bills. I mean, if you know how to do it, it's not a big deal to take Medicare. And you have an ever-growing segment of your population who are Medicare eligible, and the world may be changing soon for chiropractors and what is covered under Medicare. There's legislation out right now to expand chiropractic coverage to include exams and x-rays and therapies and other things that are within your scope of practice. So if you don't, I'm telling you, if you don't take Medicare now and that law passes, and then you all of a sudden want to enroll in Medicare, good luck in how long it's going to take you to get credentialed, because I believe that Medicare is going to be flooded with applications all of a sudden, So anyway, there is a wonderful document that in the Medicare Learning Network called Misinformation on Chiropractic Services. And this is a really great place to start if you don't know a lot about Medicare in the chiropractic space. And we're going to be referring to some of these misinformation, kind of mythbusters type things. So here's one. This is number 2. If you're non-participating, you do not have to worry about billing Medicare. That's not correct. Being non-par does not mean that you're absolved of your responsibility for billing Medicare, but what you can do is not accept assignment, which means you can have your Medicare patient pay up front, bill Medicare, and then let Medicare pay the patient directly. So that's the chief difference. And in what you can charge slightly more as a non-par provider for the spinal manipulation codes than as a par provider. So for some providers, it's worth it. They don't have a problem having the patients pay up front. They bill Medicare, Medicare cuts the patient a check. And so you still are required to file whether you are par or non-par. And so non-par providers can choose to accept assignment, but my question is, why would you do that? Because you're going to get paid 5% less than if you were a par provider. If you're a non-par provider and you don't accept assignment, you make the patient pay up front, you can charge 15% more. But if you're a non-par provider and you accept assignment, meaning you ask Medicare to pay you, they're going to pay you 95% of the par fee schedule. So you're going to get paid less than if you were a par provider. It doesn't make any fiscal sense to me to do that. Oh yeah, hands, yes.
What do you mean by the 15%? We can only charge 15% more?
I'll have a slide here on the limiting charge. Yeah, here in just a second.
Why would you do that, though? Not just for the you're a non-par, you get the money up front from the patient, why would you send it? You mean you wouldn't have the patient pay?
That's right.
Okay,
Yeah.
okay.
Yeah, in other words, you don't want the patient to pay up front, so you take the 20%, you bill Medicare, but Medicare is going to ding you 5% on that. So yes.
So the 15% premium that we charge as non-par, does the patient get that if they have supplement, do they only get 80% of
The par rate.
par rate?
Yes.
Okay, so there's no way
Yeah,
for that
and
to
I'll
be-
show you that on a slide here in just a second. Any other questions on this?
Yeah,
Yes.
one more. Do we have to disclose in some way that we're a non-par provider?
Only if you don't accept assignment. If you don't accept assignment, you would let them know that you're non-par. So yeah, I mean, in general, yes, you do, because the patient needs to know why they're having to pay more than their 20%.
Yeah, well, we explained that they're paying up front and that they're gonna be reimbursed, but I've seen in another office where they had like a sign that said, we're Is there there's no compliance
No.
requirement that you have to explain what
No.
Just the
No.
signing,
Yeah.
this is what's not covered and
Yes,
this is how.
you should have a statement in there that says we are a non-participating provider with Medicare. We are required to bill Medicare for you, but we don't accept Medicare's payments. We'll have Medicare pay you instead. So just something in very simple terms to let them know that. If you're a non-par provider, and this is what some non-par providers say, well, I went non-par because I want to avoid audits. Okay, that's the biggest old wives' tale in the world. As a matter of fact, what we're seeing now industry-wide is that more non-par providers are getting audited than par providers because non-par providers are less compliant than par providers. And that's not just Medicare, that's in commercial insurance and everywhere you're seeing more non-par audits taking place. That would be a fun session maybe to teach at one of the UVCA conferences about how to fight audits as a non-par provider, because you don't have the same, you do have some perks as a non-par provider in what the payers can require of you in an audit. I mean, they can only go back 90 days, for example. They can't go back 2 years like in a participating provider. So I don't want to get into that because we don't have that much time. But if you're a non-par provider, you're just as likely to be audited as if you're a par provider. That's a misnomer. Another one here is doctors of chiropractic, or this is the one that says you can opt out of Medicare. Doctors of chiropractic may not opt out of Medicare, and we've talked about that. So this is all in that particular booklet called Misinformation on Chiropractic Services. So the comparison between par and non-par for a participating provider, Medicare pays 5% more, okay, if you accept assignment. If you accept assignment as a non-par provider, they pay 5% less to non-par providers who accept assignment. However, if you're non-par, you cannot charge the patient more than the limiting charge, which is 115%. That's that 15% increase of the Medicare fee schedule amount. You can accept assignment on a case-by-case basis. Your appeal rights are limited. So in a non-par situation, most of the time appeals have to go, the patient has to do the appeal because Medicare is dealing directly with the patient. So if Medicare doesn't pay the charge, it's really up to the patient to be doing that appeal. Now, of course, we always help them, with that, but yes.
Can you explain what you mean by you can accept assignment on a case-by-case?
So it doesn't have to be all or nothing. So in other words, if you have a patient who's got, like financial hardship patient where they can't afford to pay the non-par rates up front, you can elect to accept assignment, but you're going to take a 5% cut. Actually you're going to take a 20% cut because you're not able to charge the limiting charge, and you're going to get paid based on the par rate, which is 5% less, plus the additional 15% more, so that's a 20% gap. It's a 20% pay cut, essentially. Does that make sense? Yeah. Okay. All right, so here are your rates. I looked as of yesterday, the 2024 rates are not up. This is simply the Virginia locality, so doesn't take into account some of your urban, like Georgetown has has their own fee schedule. Some of the other urban areas in Virginia pockets will have their own fee schedule, but this is basically what they call the rest of Virginia, which is most of Virginia. So this is the 2023 rate. So as you can see, looking at a 98941, your non-facility price, so when you're looking up the fee schedule on cms.gov, your non-facility price, because you are not considered a facility. A facility is a hospital, a nursing home, anywhere where Part A services are rendered, okay, is a facility. Now, doctors can go into facilities and bill Part B. So like, for example, a medical doctor can go to the hospital, see their patient at the hospital, and bill under the facility of the hospital, but they're going to get paid less because they're not using their own overhead. They're using the facility's overhead. So they get paid less. If you see a patient in a facility setting versus a non-facility setting, the reimbursement is less. You are non-facility in a provider's office. About $40 for the par rate, $43.45 for the non-par rate. So what happens is when you don't accept assignment, the patient pays you, this is the most you can charge the patient, the non-facility limiting charge as a non-par provider. You cannot charge a Medicare patient more than that for active treatment spinal manipulation, okay? If you're billing Medicare with an AT modifier, that's the maximum you can charge the patient. And unlike all other billing rules, that's the most you can put on the claim form. So you can't put like a $60 charge on a non-par claim form and then do the reduction to $43.45. You bill $43.45. You bill what you charge the patient, okay, as a non-par provider. So the patient pays the difference between the non-facility price and the limiting charge, which is, I don't know, $3 or $4. When they get reimbursed, the patient is going to receive 80% of this, okay? Not 80% of this. They're going to pay you this. They're going to receive 80% of this after their deductible is met on the 98940, 98941, 98942 AT claims, okay? Does that make sense to everybody? Yes?
What happens if you charge more than 115% of the limiting?
You're going to have to write it off. You cannot charge the patient more than this as a non-par provider with Medicare for AT services.
No, for not active care.
Oh, yeah, not active care, you can charge whatever you want.
Oh.
Once the patient has reached maintenance status,
Yeah.
you have them sign the ABN form. We'll do this after lunch. You have them sign the ABN form. You put your charges on the ABN form, and then whatever they agree to, then that's different than this.
So for active care, we can charge them up to 115% of the limiting?
No, you can charge them up to the limiting charge, which is 115% of the regular fee schedule.
Of the par fee schedule?
Yes.
Oh, got it, okay.
Does that make sense? I know it's a little bit confusing, but I just want to make sure everybody's got that. Yes?
So you're saying if we're participating, those prices are the amounts that we're supposed to be billing for those codes?
No, different. If you're non-par, these are the amounts that should be on the claim form for the AT claims. If you are par, you can, like, if your regular fee is $40, you can bill $40. You're going to take a contractual write-off because you're par and you have a contract, so you're going to take a contractual write-off. Medicare is going to allow $27.61, pay you 80% of that. right? And then the Medigap or the patient is going to have to pay the other 20%. Okay? Yes?
Could that possibly cause like a dual fee schedule?
No, because a dual fee schedule is only a dual fee schedule when it is not under a contract. Because you have dual fee schedules all the time, right? I mean, you have your Anthem allowables, you have, all of these allowables. And so for all of your claims, what you're supposed to do, all right, except for non-par, non-assigned claims, you bill your standard fee. You let the insurance company give you an EOB that says this is what the allowable is. You do the contractual write-off, then you apply your payment. For non-par, Medicare, non-assigned claims, that's what has to go on the claim form. Okay? So I know it's a little bit confusing, but it is kind of a billing exception that you need to be aware of. Yes, Suzette, did you have a question? Okay. Okay. Remember that the limiting charge only applies when the provider does not accept assignment. If you accept assignment, you can't charge the patient the limiting charge. You can charge the patient based on the par amount. You'll get paid 95% of that fee schedule. Okay. Here's another one. Non-par providers do not have the same documentation requirements. Totally not true. We'll get into that here in just a few minutes. After we do this, we're going to take a little bit of a break to stretch your legs, and then we'll get to work on the documentation side of things. After you're enrolled, if you haven't enrolled in Medicare, you're going to be issued what's called a PTAN number, which stands for Provider Transaction Access Number. You'll then need to register to send your electronic claims. Medicare does not accept paper claims, except in some very exceptional circumstances, and I can talk to you about that, but you wouldn't want to send paper claims to Medicare. It's going to take you twice as long to get paid. So you need to register to send electronic claims through your clearinghouse. It doesn't automatically happen. You have to do something called an EDI enrollment. You may only submit claims for dates of service on or after the effective date of your enrollment. Every 5 years, you'll have to revalidate your enrollment, and then if you have any changes, you would want to report that immediately through your PACOS account. PACOS is the enrollment portal for Medicare. It's actually very, very simple to enroll as a Medicare provider, and we do a lot of credentialing for providers. And Medicare is probably the easiest, simplest, and quickest one. Plus, the cool thing about enrolling as a Medicare provider is from the second you put your application in, as long as there's not a problem with your license or you haven't had a suspension or malpractice or anything like that, and you get approved, they're going to backdate that approval all the way to the date of the application. So you will technically be a provider from the date you submitted the application. Now, you won't be able to bill Medicare patients until you actually are approved formally. You've done your EDI enrollment, but you'd be able to go back and capture all of those claims, and you can start seeing those Medicare patients as soon as you submit the application. Okay? Any questions on provider enrollment? Okay. If you guys have any questions, additional specific questions about provider enrollment, take my card. On our Gold Star Medical website, there's a Contact Us link at the top of the website. It's goldstarmedical.net, and it's on my card. And in there, there's a link to schedule a 30-minute call with me, a complimentary 30-minute call. So if at the end of this, you guys have questions and you want to schedule an additional call that goes over some specific issues with your practice, please feel free to go online, go to our website, and click on that schedule a call, and I'll be happy to talk to you guys, okay? And it's no charge. The other thing is, going back to Medicare Advantage, it used to be, up until 2019, that providers did not have to be enrolled in Medicare to see Medicare Advantage patients. That changed in 2019. So now, if you want to see a Medicare Advantage patient, even billing it out of network or as a non-PAR provider, you must be a PAR provider, or you must be enrolled as either a PAR or non-PAR provider with Medicare Part B, with original Medicare, okay? So just FYI on that. So, like Chris Perrin said, it hasn't changed since he was born. I mean, literally, Medicare has had the same coverage since I started working in the billing world with Medicare and chiropractors. There have only been ever, and up until this point in history, 3 codes that are covered under the chiropractic benefit for Medicare. And of course, prior to, I believe, the 98940 through 98942 codes were developed, I think, about 20 years ago. Before that, there was another spinal manipulation code, A9270 or something like that, that was the spinal manipulation code that we used to bill for Medicare. There was no such thing as an AT modifier, but basically, the only thing covered has always been spinal manipulation to correct a subluxation. Now, we're going to be reviewing the Medicare Benefit Policy Manual, Chapter 15, which addresses chiropractor services, Subchapter 30.5. And it's very, very clear that coverage extends only to treatment by means of manual manipulation of the spine to correct a subluxation. Any other diagnosis, any other methodology is not covered. Now, let's get manual manipulation out of the way. Manual manipulation means with hands or any instrument that allows bones to move. So, activator, pro adjuster is fine. I always get that question. So it's perfectly fine for you to use an activator on your Medicare patients. Perfectly fine if you have pro adjuster. You can't run crystals over their spine. That's not considered, spinal manipulation. So there are certain adjusting techniques that would not be considered manual manipulation or manipulation by hands or hand-assisted instrument, okay? So, and only to correct a subluxation. So that already gives us a clue as to what diagnosis code or codes are needed on our claim forms, right? Subluxation codes, and we'll go into that after lunch when we go into the billing and coding part of it. All other services furnished, and this is really, really important, folks, all other services furnished or ordered by a chiropractor are not payable. So let's say you don't, you want to use X-ray to justify medical necessity for a subluxation. You want to prove subluxation with an X-ray, and you don't have X-ray in your office, and you send the patient to a radiology clinic and you write an order for that X-ray. If that radiology clinic puts you on as the ordering provider, the X-ray will not get paid. All right, if you're the ordering provider. So you billers, your chiropractor's name and NPI number should never be in box 17. Okay, because for any service other than spinal manipulation to correct a subluxation, okay? So it's not just furnished, but also ordered. And this actually is very, very important in medically integrated practices, okay? Where, are any of you doing medical integration? Where you have a nurse practitioner? Okay, if you did, we would have to have a separate conversation because this is a big problem where the patient comes in, sees the chiropractor, they order an X-ray, the nurse practitioner takes the X-ray so that Medicare will pay for it, and then the chiropractor's name is on the order, so then Medicare still doesn't pay for it. So, or they order the exam and the chiropractor is listed as the ordering provider, they send the patient over to the nurse practitioner for an exam because exams are covered under the nurse practitioner, right? But if they're listed as the ordering provider, not payable. So be aware of that. Coverage extends only to treatment to correct a subluxation. Period. End of conversation. Anything else? Not covered. Maintenance therapy. Medicare states under the manual that chiropractic maintenance therapy is not considered to be medically reasonable or necessary. And probably these are the saddest words in medicine. And it says, maintenance therapy is defined as a treatment plan that seeks to prevent disease, promote health, and prolong and enhance the quality of life. We will not pay for that. You know, your Medicare patients will not get coverage if we try to prolong or enhance the quality of their life, but if they have a bone out of place, we'll cover that, right? What do we do as chiropractors? Promote and enhance the quality of life, right? Promote wellness, prevent disease. It's what we are in chiropractic. And to me, that's the biggest slap in the face that Medicare gives us, right? Is the fact that they say that they are not going to cover what we do, right? What we do and what makes us so beneficial. It's kind of like what's going on right now in big pharma with these injections for weight loss, like the Ozempic and Mounjaro and stuff. And they say even though obesity is classified by the CDC as a disease, Medicare and some of the other commercial payers, or many of the other commercial payers, won't cover it unless you're diabetic, right? But obesity is a disease, and what does that disease cause? Diabetes, right? So let's just get you, let's just be obese, and as soon as you have diabetes, we're going to cover that, and you're going to lose some weight, right? But let's not prevent that you from getting diabetes by giving you this so that you can lose weight. I mean, it's just crazy, but that's our medical world, okay? That's the medical insurance world. They're not here to promote wellness. The PPACA actually made great strides in that by requiring certain preventative screenings to be covered at 100%, like colonoscopies and mammograms and things like that. But they haven't gotten as far as this yet. This is still very, very ancient and archaic thinking. Yes?
I have a question on the previous slide.
Yeah.
That spoke to anything ordered by chiropractors.
Uh-huh.
I know this is a Medicare class, but are other insurers following suit with that?
No.
So typically.
No, because like in commercial plans, you can order a brace for your patients, you can order physical therapy and get physical therapy paid. So yeah, no, this is just Medicare. Now there may be some other payers that have policy restrictions, but this is like a corporate policy. This is like all Medicare. And this is Medicare Advantage too, so this applies to Medicare Advantage as well. Yes?
Because Blue Cross Blue Shield has been denying when we do x-rays and MRIs now, they're saying that we can't write those. So we've had a couple of those denials.
Yeah. Talk to me afterwards. I'll tell you how to appeal those. I love a good fight. Oh yeah, I love a good fight, okay? And so it states, under maintenance therapy, it states, when further clinical improvement cannot reasonably be expected from continuous ongoing care, and the chiropractic treatment becomes supportive rather than corrective in nature, the treatment is then considered maintenance therapy, all right? And we'll talk about how to bill that on a claim if it's required by you to do so. So how do you demonstrate a subluxation for Medicare purposes? There are two ways that you can demonstrate a subluxation. One is through physical exam and the other is through x-ray. Either or works. Medicare does not cover those procedures, but you are required to do one or the other in order to prove medical necessity. Yes, Aziz, what was your question?
The only two ways.
The only two ways. Okay, and the exam that you do is a very specific type of exam called a PART exam, P-A-R-T, and basically what you are evaluating on the musculoskeletal and nervous system is pain and tenderness, evaluated in terms of location, quality, and intensity. So that's one documentation element. Asymmetry, misalignment identified in a sectional, like cervical, thoracic, lumbar, or segmental level, L4, L5, C7. Range of motion abnormality, so spinal range of motion, changes in active, passive, and accessory joint movements, resulting in an increase or decrease of sectional or segmental mobility, and tissue tone changes in the characteristics of contiguous or associated soft tissues, including skin, fascia, muscle, and ligament. So the part exam, and I'm just going to kind of demonstrate this with a form because I think it's a good visual way. So the P stands for pain, right? Pain. And typically the P portion of a part exam is what, doctors? Subjective. Okay? So the pain portion is usually subjective. Now, you can do certain tests to elicit a pain response and to basically prove whether it's malingering or not and all of that. But for the most part, you know, when you're asking a patient about pain, you're saying, where does it hurt, right? They're telling you, okay? You can't feel that pain. You may not be able to see that pain. You can test for it, but essentially this part of the part exam is usually something that the patient does, either on a like a tablet, at a kiosk before they check in for their services. ChiroTouch has that, where they can do the, you know, mark on the body where you're hurting, where you have pain. What is your pain scale on a scale of 1 to 10? What kind of pain is it? Aching, stabbing, burning, numb, pins and needles, and that type of thing. So this form is basically just a visual demonstration of what elements you could document for the P portion of the part exam, okay? And so this piece of it is the P portion of the part exam. Then you have your exam form, which again, most of you, if you're using an EMR, this should be templated for you in your EMR, and a very specific template for a part exam, not just a regular exam, but a part exam. So if you're ever audited and Medicare asks you for documentation of medical necessity, you can send them the results of that part exam, okay? So you have asymmetry, you have tissue abnormalities that you can document, and then you have on the last page all of your neurological and orthopedic tests that you could possibly do. And again, this is just an example of a form. I have this on a paper format, so if you want a copy of it, I'm happy to send it to you. But you know, the asymmetry is going to be the A part, your range of motion assessment is the R, and then the tissue changes is the T portion of it. And so for a part exam to be valid, 2 of the 4 criteria need to be met, okay? One of the 2 must be asymmetry or range of motion. So you can have pain and asymmetry. You can have pain and range of motion abnormalities. You can have asymmetry and tissue changes, right? Range of motion and tissue changes. But if all you document is pain and tissue changes, P and T, no good, all right? One of the 2 of that 4 criteria has to be either asymmetry or range of motion abnormality, okay? And so please be sure if your doctors aren't here that you're sharing that with them, you know, when you look over their documentation for these Medicare patients. Now, an X-ray can also be used to document subluxation. Medicare states the X-ray has to have been taken at a time reasonably proximate to the initiation of a course of treatment, which is really interesting here because they say that prior or 3 months after you start treatment. How can that be? Right? Yes, I want to prove medical necessity for a subluxation for my patient that I saw on December 1st, but I'm not going to do an X-ray until January 15th. And it would be valid. It would be valid because 12 months before or 3 months after. If the condition is chronic, all right, and the condition has existed longer than 12 months, and there's a reasonable basis for concluding that the condition is permanent, then you do not have to have a re-X-ray every 12 months, okay? You just need to document that this is a chronic condition that the patient has had for more than 12 months, and that the X-ray that you took documenting the chronic condition basically the condition has not changed. Now, best practice for malpractice, I'd probably be X-raying every once in a while, to make sure there's nothing new, that additional degeneration. A patient, in their 60s and 70s, you may not see, significant changes on an X-ray, but once they get into their late 70s, into their 80s, then there could be rapid and significant changes in their musculoskeletal system as they age. You guys are the doctors, so just kind of be wise about that, all right? Yes?
So just to be clear, the pain and the tissue changes, that would be more of a maintenance.
Yeah.
And then the more active care, active treatment would be the percentage.
As long as you have 2 of the 4 criteria established for treating that patient, then and one of them is, at least one of them is asymmetry or range of motion issues, then you can continue to keep them on active treatment. Okay? So what are some of the conditions that warrant active treatment? Now, again, these are a lot of misnomers that I hear, so I like to point this out. I hear doctors say all the time, Medicare doesn't cover chronic conditions, right? That's maintenance. Well, that's actually not true. Medicare does consider chronic conditions for treatment. How you document it is going to determine whether you can bill Medicare or not. So the first bullet point that Medicare puts in Chapter 15 is the acute subluxation. A patient's condition is considered acute when the patient is being treated for a new injury, new diagnosis, identified by X-ray or physical exam as specified above or in the previous slides. The result of the manipulation is expected to be an improvement in or arrest of or progression of the patient's condition, okay? So, if you see an 86-year-old Medicare patient and you do an X-ray, you're probably going to find a lot of issues in their spine, right? Degenerative changes, tissue, disc changes, narrowing, and so on and so forth, right? When are you going to be able to treat that patient until those degenerative changes go away? No, they're not going to go away, because they are skeletal changes that are not going to be improved, right? So once the patient reaches MMI, maximum medical improvement, at the point that they're at in their health status, okay? So maximum medical improvement may not be pain-free, right? Maximum medical improvement may not be, pain-free maximum medical improvement may not be possible for certain Medicare patients. But if you take them as far as you can to pre-injury or diagnosis status, then that would be considered active treatment. Chronic subluxations, and I've actually, I thought I had it memorized, but I'm not going to try to do this from memory, but usually I can spout it off. It says a patient's condition is considered chronic when it is not expected to significantly improve or be resolved with further treatment, okay, as is the case with an acute condition, but where continued therapy can be expected to result in some, this is the important word, functional improvement. Functional improvement. So, what is the one of the things when you're doing a report of findings, or if you're staff and you have heard your doctor do a report of findings, one of the very common talking points in a report of findings is pain is the last thing to show up and the first thing to go away, right? Right? You can have had spinal problems for a long time, but pain is driving you here. The good news is we're going to be able to get you out of pain fairly quickly, right? And it's going to improve your functional, it's going to improve your activities of daily living because you're going to be able to move around pain-free, right? So pain is a very, very poor way to document chronic conditions, all right? It's not just about the pain, it's what is the pain resulting in as far as functional limitations. So if the pain is so severe that the patient can't, get into their car, without significant pain, then yeah, okay, now we have a functional limitation, but that has to be documented, guys, okay? It can't just be about the pain, it's about the pain and what that pain is resulting in as far as functional limitations. If you want to treat your patients for chronic conditions, which you should be, because Medicare covers it. Medicare covers these chronic conditions. It's just how you advise them and how you treat them for the chronic conditions and how you document it will result in whether Medicare is going to cover those or not. Under the treatment parameters, it states that I get this question a lot. How many visits can I get? Is it 12 visits? I treat my Medicare patients 12 visits and then I move them to maintenance. Well, is that right? Not according to Medicare. Medicare actually doesn't give a visit limitation. Now, they do give some guidelines here, and one of the guidelines is, it states that the chiropractor should be afforded the opportunity to effect improvement or arrest or retard deterioration, right, within what they say, a reasonable and generally predictable period of time. Okay? Whoa, what is that? That's where you fall back on your guidelines, like your CCGPP guidelines for treatment of low back pain, or you fall back on some of the science behind chiropractic, okay? And, if you state in your treatment plan that we base our treatment plans per the CCGPP guidelines for treatment of low back pain, and this patient presents a classic example of that, right? Then you have a basis for that treatment, okay? It does state that it states that acute subluxation may require as many as 3 months of treatment, okay? But some require very little treatment. In the first several days, treatment may be quite frequent, 3 times a week, daily visits, but decreasing in frequency with time as improvement is obtained. So they give you some very, very broad and general guidance as far as numbers of visits, but Medicare is not allowed actually to state how many visits are approved, okay? And if you have Medicare Advantage plans that have visit limits imposed on their plans, you can fight those all day long because they have to follow Medicare guidelines. You can fight those all day long and you'll win, okay? As long as your documentation proves the need for additional treatment, okay? Now, you might have to send in provider notes and things like that, but you can fight those all day long because your Medicare Advantage plans have to follow these rules, okay? They are not exempt from them in any way as much as they would like to believe they are, okay? So this is one of the misinformation of chiropractic services. This was number 1 on misinformation. The number 1 question, that there's a 12-visit cap or limit for chiropractic services. Now, one of the things that it does state is that your contractor, i.e. Palmetto or Novitas, depending on who your Medicare contractor is when you're billing out the claims, they can impose audit screens, meaning like once you've hit the 12 visits, they may screen further visits for medical necessity and ask you for notes, but they can't just outright deny it, okay? Typically what will happen is if you're going well beyond the 12 visits, the payers have automatic edits that will pull that claim out of processing and into what's called a prepayment audit, and they'll say, we need to see your provider notes so that you can prove that. Now, it doesn't happen all the time. It's a fairly random thing, but be aware that if you do exceed that 12 visit cap, or you exceed a certain threshold like 3 months of treatment, as stated in the policy, you may start getting prepayment screenings, okay? So your Medicare administrative contractors for the state of Virginia are Palmetto GBA, which is most of Virginia. The claims are billed to Palmetto, which is jurisdiction M, and Novitas, which is jurisdiction L. That's the Part B MAC for the counties of Arlington and Fairfax and Alexandria, and the city of Alexandria. So if you practice in those counties or in that city, then you would bill your claims to Novitas, okay? Medicare has policy documents called LCDs and LCAs. LCD stands for Local Coverage Determination. LCA stands for Local Coverage Article. The LCDs usually provide information on how to establish medical necessity, limitations, treatment limitations, and documentation requirements for initial and subsequent visits. Your LCA provides billing and coding guidance, what modifiers to use, how to bill out the claims, what primary diagnosis codes should be used. So those are going to be found in your LCA, and then your LCD is going to be more about clinical documentation requirements. General rule of thumb for using an LCD or LCA to establish your documentation templates or to look at your billing requirements is always use the LCD or LCA for your MAC, all right? I've seen there are some Medicare administrative contractors out there like Noridian, which does a lot of West Coast policies. Their LCDs are actually amazing. They are so thorough and so detailed. And I often see providers over here on the East Coast pull a Noridian LCD to argue a claim, and basically Medicare says, no, that's not, that's the wrong LCD for your area. You have to follow the LCD, or if there is no LCD, you have to go back to Chapter 15 and follow the national document, okay? And so always use the most recent version. These change every year as diagnosis codes are updated, so always make sure you have the most recent version. This is the home page for Palmetto, and you can see that there are, I just wanted to kind of show it to you. So if you want to find your LCD or your LCA and you're in Palmetto, you go to the home page, palmettogba.com. Make sure you choose your correct jurisdiction, because they do have several jurisdictions. And then what you do is you look for the medical policy link, right? And then follow the guidance. You can type in your CPT code, you can type in chiropractic, and it will pull up, if there is an LCD and there's an LCA, it will pull that up for you, and you'll be able to get a PDF of that document so that you can review it with your billing staff, and you can review it with your clinicians. If you're a billing staff and you're thinking that maybe the clinician's documentation isn't really up to snuff, you can provide them with a copy of the LCD. Here's Novitas, and again, for Novitas, they're down here on the left side. There's a menu bar. Just look for medical policy /LCD. This one has come from Novitas, and you'll notice that the Novitas does not have an LCD for chiropractic services. They only have an LCA. And so in the absence of an LCD, the national coverage document will apply, which is your Medicare Benefit Policy Manual, Chapter 15. You have to go back there to get your documentation requirements. Now, there are other aids for documentation compliance for providers. And I'm really abbreviating this documentation compliance piece to about an hour, because, or a little more than an hour, but literally, I know that in the past we've had Evan and Chris Anderson come and teach documentation compliance, and we could teach a 6-hour class on this for the doctors. But because we have a mixed crowd here, You know, I'm giving you really the highlight points of documentation compliance, and, you know, hopefully some takeaways and take home to implement on Monday type of things. But it can be, you know, it can be expanded to be a much more significant portion. You know, maybe that's something that we consider at a future conference, Suzette, or something like that. But let's talk about what some of these additional aids are for documentation compliance. So one of the things that I am a strong proponent of are OATs. And OATs stands for Outcome Assessment Tools. So one of the things that we established in Medicare as far as establishing medical necessity is that you have to document functional deficit, right? Functional deficits. And one of the ways to document functional deficits is through outcome assessment tools. It's basically a survey that you give your patient that says, what is this condition preventing you from doing regularly on a daily basis? And they fill it out, and there are, and I'm going to show you a website where they could literally fill it out online. It scores it for you. It automatically gives you a score. You can download it into a PDF and put it into the patient chart. Or you can take the same tests and you can ask your EMR company to make a template for you that you can then have your patient fill out at certain intervals during their treatment plan. So some of the examples of standardized OATs tools are, I'll be with you in just a sec, are your Oswestry Disability Index, typically used for low back conditions, the VAS pain scale. Vernon and Meyer is one for cervical conditions. If your patient has a hip condition, it would be WOMAC. And I know Medicare doesn't cover knees, but like if you're doing functional assessments for patients with osteoarthritis of the knees or things like that, the KOOS, which is the knee osteoarthritis scoring system. And you can actually find these outcome assessment documents on a website that we love using called orthopedicscore.com. And I'm just going to show you, this is what it looks like. This is the home page of Orthopedic Score. And so what you do is you find the region, knee, foot, ankle, wrist, hand, lumbar spine, cervical spine. They even have them for psych. And then they have a link to the different tests, right? So here's the Oswestry. So when you go online, this actually, if you click on this, it opens up the document for you or for the patient. So you could literally sit the patient down at a laptop and pull up the test, right? And say, okay, we're going to have you fill this document out. And then when you're done, let me know. And then what you do is you come in, you create a PDF of it, and you put it in their chart. Okay, it's as simple as that, because this is something that if you have the patient doing this at the correct intervals and you're ever audited, the auditors will hardly ever have a problem with anything that you've done, okay, on that patient. So this is what it looks like, and it's just like a little, they take their mouse and they check, what is the pain intensity, personal care, lifting, walking, standing, sleeping. What about your sex life? Is it affecting your sex life? What about your social life? So all of these are filled out by the patient, and as it's filled out, it's automatically scoring the disability index for that patient. So that's the Oswestry. The patient can fill out the OATs forms online, save it as a PDF, and those OATs, how often should you do it? On the initial exam, at the re-exams, you should be doing the OATs. And for Medicare patients, every 30 days while they're under active care. Okay, so if you don't do a re-exam every 30 days, at least have them do the OATs every 30 days. So if you feel, if you look at their score from the beginning and then you do a score in 30 days and they have really significantly improved, then you may be able to reduce their care plan down to maintenance care, all right? So you should be doing it about every 30 days for that Medicare patient. The other really, really, really important tool that Medicare has actually developed for the chiropractic profession is something called the Job Aid for chiropractors. And essentially, this is a bulletproof documentation template that Medicare has created for doctors of chiropractic. And so you could take, if you don't already have this in your EMR, you could take this Job Aid and you could take all the different bullet points within the Job Aid and ask your EMR system to create that template for you. So when it comes time for you to document your initial visit and your subsequent visits, you have the Medicare template for it. All right? It takes all the guesswork out of how you document a Medicare treatment plan. So this was developed in 2021, so it's a fairly new tool. And essentially, this is the exact form that auditors use to audit your charts. They go exactly by the Job Aid. They're actually required under the contract to do that, all right? So if you're doing everything in the Job Aid, or you're handling all of the documentation elements within that Job Aid, and you're doing it properly, then if you are audited, there will be no problem with recoupments or anything like that, okay? So this is what it looks like. You see how it has the little boxes, the check boxes. So this is general documentation guidance to establish to establish the subluxation, okay? And it tells you what to include. The dated documentation of the initial exam, include the primary diagnosis of subluxation, including levels. So your documentation guidance is the patient's name and date of service on all pages of all forms of your document, okay? Not just on page 1, but on all pages of all forms. I also add date of birth to that. Then you document your subluxation. This is in your initial exam, okay? And then in addition, here are all the elements of the initial evaluation that you need to cover, all right, in order to properly document an initial exam and a part exam for the patient. And that includes the history. You know, one of the things that I see, unfortunately, because we do quite a bit of auditing of provider charts, they'll give me a call and they'll say, hey, can you look at my notes and tell me, you know, where the deficiencies are, because they want us to audit before the insurance company does, which is a good thing to do, right? You know, let us find the problems so you can make those corrections, so that if you ever are audited, then, you know, you can say, yeah, I know, we really sucked 2 years ago, but we've already made changes to improve. And then if worst case scenario, you have a recoupment, but you don't have a lot of all the additional penalties imposed because you've already been, you know, brought into compliance. But so, you know, one of the things that I see as a big deficiency is they don't take a proper history, all right? There's no documentation of, or there's very, very little documentation in family history or past health history. And it talks about the ones that are recommended. So if it states recommended, it means it should be in there, but the ones that don't say recommended are mandatory, okay, on the Job Aid. And then you have your part exam, documentation of presence or absence of subluxation for every visit, all right, for every visit, and the treatment given on that day. So that's your initial evaluation. Then under the Job Aid, Medicare requires you to write a treatment plan. This is another one where I see, you know, the doctors ask me, you know, check my charts, and I look at the chart and I don't see a treatment plan. I don't see a plan of care that outlines the frequency and duration of visits, specific treatment goals, and the objective measures to evaluate treatment effectiveness. What are those objective measures? OATs. Those are the OATs right there. Okay, so they're telling you that they want OATs. Subsequent visit. And so for every chiropractic treatment under active care, you need to have these elements in your documentation in order to protect yourself from recoupments. All right? So, just a brief mention of the history of the patient. Patient history was taken on this date, reviewing the chief complaint again, a system review if relevant. Now, you don't have to do a full part exam at every visit, but assessment of change in patient condition since last visit, okay? So use the part elements to do an assessment of any changes that may have taken place for the better or worse in the part exam, and an evaluation of treatment effectiveness. So some type of wording in your documentation that states, based on the original plan of care, this patient is responding as expected, or this patient is responding better than expected or worse than expected due to noncompliance. Those are really important words to add into your documentation, is your own evaluation of the effectiveness of the treatment and why. Whether the patient was compliant, motivated, non-compliant, all of those should be added to your documentation elements. And then you have the general guidelines. So making sure that the AT modifier is on the claim. If you're audited, submitting records for all dates of service on the claim. Make sure the documentation is legible. So if you're still using travel cards, guys, don't. I'm just going to say it, don't. But if you do, make sure that they are completely filled out, they're legible, and if you use any kind of acronyms that are not medical standard acronyms, you better provide a legend of what those acronyms are to your auditor, okay? Include abbreviation key and any other documentation that supports medical necessity, like your OATS forms and things like that, okay? So, how do you, yes, go ahead.
So the OATS form does not fit underneath the part for medical necessity. That's
The OATS is completely different. It's not a
it would
part
not be
exam.
part- it
No.
would not be
No.
eligible for any part
No,
exam.
the OATS is actually part of your history, okay?
Yeah.
So the OATS would go into the history portion. So what is going on? It's because it's the patient giving you a survey of how they are feeling, from one interval to another, functionally.
So it can never be used to show a point of continued active care just due to that.
It can if the patient's functional limitations deteriorate, sure. You can, it can be a justification, but you still have to do your exam to confirm, right? It doesn't take the place of an exam. Does that make sense?
Yeah.
Okay. So to implement this, all right, the first thing that I would do is make sure that you're working with your EMR company. If you're doing your notes, through ChiroTouch or Eclipse or whatever it might be, Jane, make sure that you are working with your EMR company, that you have these Medicare templates based on the job aid, not based on the EMR company's templates, okay? Because their templates are going to be very generic in nature. So make sure that those templates match and mirror the chiropractic job aid. You may want to template the OATS forms that you want to use, so that this way you don't have to go to an outside site. If your EMR is robust enough to where you can build the OATS forms into the EMR, that's even better, because then you don't have to download a PDF and upload it into the patient's chart and all that kind of stuff. Have the patient fill out the OATS at the initial exam every 30 days during active treatment. And if you're treating chronic patients, if they're returning for care with functional deficits, have them fill out that OATS. This is going to be extremely important if you're billing for chronic care to Medicare, all right? And the other payers as well. Yes?
If you follow up with your software, like ChiroTouch or Jane, to ask them if the forms that they have, because I know ChiroTouch has that OATS template,
Mm-hmm.
to verify if it is compared to the job aid, and if it's not, are they required to give you an updated form to the job aid?
I don't know the answer to that.
Jane is fairly new. Jane's
Yeah, it's probably going to be based on the software company, whether they would actually make those changes for you, or if you would have to go into the template and make the changes yourself. Yeah, I don't really know. It's going to be based on the software itself, but you could always request an update, but sometimes it takes 6 months for them to get around to it. So I don't know. And I'm not, we're still learning more about the ChiroTouch cloud system. That's a whole other conversation. We'll talk about that over lunch.